All right. Thanks everyone for joining us tonight. A couple other people joining us here, but this webinar will be recorded and sent out through email link. So if you need to refer back to this presentation for information, it will be available. Brief introduction for myself. My name is Faraz Khan. I'm an interventional radiologist with my group here called IR Centers. We're a minimally invasive healthcare company, and we're a team of interventional radiologists spread out all throughout the country. And we specialize in doing minimally invasive procedures. We have a wide variety of procedures available for patients. Today's talk is specifically about knee pain, and we're working within the musculoskeletal realm. Our partner companies with Loudon Medical Group, the Orthopedic Group, working with doctors Akhtar, Candidacy, Gavin, and Dr. Kavanaugh, as well as their APPs, PAs, and NPs that they work with. Great group. So today's talk is going to be more focused on the orthopedic side, but in addition to some of those procedures, we do work with patients on the GI side, with those with hemorrhoids, for example, as well as the urology space, working with men with enlarged prostates, for example, plus a whole other slew of procedures that we do offer. But these are our main uh, sites of procedures that we offer. And today's talk is going to be focusing more on knee pain and what treatment options we have available for knee pain. All right, a little bit about myself. Like I said, my name is Faraz Khan. I'm an interventional radiologist, and I work out of our center in Lansdowne. I am born and raised from Western New York, up in Rochester, and did my undergraduate studies there as well. I went to medical school on Long Island at Stony Brook University, and subsequently completed my residency and subspecialty fellowship training up in Albany. So all throughout New York. Family decided to bring me on down here to Virginia, and I've been really enjoying it so far. And that's why I'm relocated here. But I've been having a great experience in my past working with patients and working with a lot of the local patients here in Virginia as well. My partner that I work with, Dr. Rachel Pachowiak, wasn't able to join us tonight, but her and I worked together in our Lansdowne office. So if you are working with us, you'll be working with either myself or Dr. Pachowiak. Dr. Pachowiak did her training, her undergraduate training back in Buffalo, so another Western New York native. And then she subsequently did her residency training in New Jersey and subspecialty fellowship training at Mount Sinai in Manhattan. She's been with our group for quite some time. She does a wide variety of procedures as well, including prostatic artery embolization, hemorrhoidal artery embolization, and then some of our musculoskeletal embolizations as well. So a little introduction of what interventional radiology is, or vascular interventional radiology. This is a subspecialty of diagnostic radiology. We receive the same training, but we take it a step further where we're able to interpret imaging, taking a look at X-rays, ultrasounds, CAT scans, MRIs, but we then use that information to help us guide and do procedures. So we're able to both diagnose, interpret, and treat patients all in one setting. This allows us to offer minimally invasive procedures that have decreased risk to the patient and help to improve health outcomes. And a lot of the times it's less recovery than, comparable open surgeries, for example. So it's definitely preferred in our patients that we see. So today's focus is going to be about osteoarthritis, and in particular, arthritis that affects the knee. So this is a very prevalent problem here in the United States, with about 30 million patients affected with osteoarthritis in total, the knee being the most common site. Now, one of the treatments for arthritis in general is to use over-the-counter medications like non-steroidal anti-inflammatory agents. We're talking about things like Advil, Motrin, Aleve, naproxen. These medications that are sometimes the first-line treatment for some of these types of pain. Now, these medications are not benign. They come with risks as well. For example, there's over 100,000 hospitalizations related to NSAID-related GI toxicity. That means ulcers in the stomach, bleeding. These aren't medications that we can indefinitely take forever. They do come with some risk as well. So While we like to start with some medications to help out with some pain, it's definitely not something that we like patients to go on long term because of this issue of causing problems long term with ulcers or bleeding. Now, just because of that, there is this subselect of patients that actually have such bad related complications from their NSAID therapy, it leads to death. Over 16,000 patients have been reported to have death related to NSAID toxicity. And that goes back to the ulcers and bleeding that we're talking about. Sometimes the bleeding can be so severe, it's really requiring blood transfusions, being in an ICU level of care. So these medications are certainly not benign and can cause problems. Now, one of the other treatments available for knee osteoarthritis are injections, whether that's steroid injections or hyaluronic acid, such as Synvisc or Orthovisc. These medications are also available. So about more than 4 million knee injections are performed every year here in the US. There are different treatment options available. So a couple different pictures here showing what's available within the treatment landscape. Starting from the left-hand side, this is a procedure called genicular nerve ablation, where under imaging guidance, we're able to insert a radio frequency probe into different areas along that knee joint where these nerves lie, and then use a radio frequency pulse to ablate the nerve or kind of destroy some of that nerve tissue. If you don't have the sensory nerves into that knee joint, then you don't have that knee pain because of those nerves not being present anymore. The second-hand image is an intraoperative image of a surgeon performing a knee replacement. So they make a large incision on the front of your knee, kind of spread some of that tissue, move some of your bones, remove some of that damaged cartilage, and then kind of replace it with that fourth-hand image with a metal prosthesis that we see, and then put you all back together. And then we briefly mentioned this before, but this third-hand image showing injections into the knee joint, whether that's steroids or a hyaluronic acid injection like Orthovisc or Synvisc. Those are certainly great options available. Now, the rationale for an orthopedic embolization, and in particular for tonight's talk, what we call a genicular artery embolization. Genicular just refers to the arteries and nerves involving the knee joint. So an embolization of the knee arteries. Why this came to be is just based on some of the research that we have available. We know that patients that have osteoarthritis have some sort of synovial inflammation. The synovium is a lining around a joint space. We have synovium around the knee joint, the ankle joints, the shoulder, the hip joints. Wherever you have a joint space, you also have this layer, which is almost like a saran wrap layer around a joint space. When that becomes inflamed, whether you have any sort of underlying injury, you have osteoarthritis, you have an inflammatory disease process, that layer or lining of that joint space becomes thickened and inflamed. At the cellular level, your body will start to produce a number of inflammatory cytokines. What that means are small little biochemical markers that your body produces at the cellular level to communicate to other parts of your body that you have some inflammation going on. Now, one of these in particular increases the number and size of the blood vessels that you have present within your joint space. The reasoning sometimes behind is hypothesized that your body is trying to increase oxygen-rich nutrients and blood to your joint space to try to help it heal. Now, unfortunately, after we get to a certain age, we're unable to regrow our own cartilage. And instead, your body starts to produce more nerve fibers and increase the amount of blood flow to that area. That's what we call angiogenesis, the development of new blood vessels. This leads to more blood flow going towards your joint space, which can lead to more inflammation and more pain associated through all this. So it's this unfortunate cycle of increased blood flow, increased inflammation, and increased pain. Now, our procedure, the genicular artery embolization procedure, addresses the blood flow aspect. Our concept behind this procedure is to reduce the overall amount of blood flow to break this cycle. By being able to reduce the amount of blood flow to a joint space, we're able to decrease the inflammation, to reduce some of these inflammatory markers at the cellular level, which helps to decrease the number of nerves and inflammation, which decreases the overall pain signal going to your brain. Here at the cellular level, we have a little schematic here, and it's definitely a bit busy here with all these abbreviations, but the main concept around here is when there is this underlying damage to some of this cartilage, as we see on the screen right, this signals to your body to produce inflammatory signal markers, and some of them increase sensory nerve fibers and blood vessels, which leads to pain and increased blood flow to that joint space. Now, our team here at IR Centers has been working with this procedure for a number of years. We've been doing a lot of research to help support some of the procedures that we do as well. Some of my partners, Dr. Bagla and Dr. Pachowiak, who I previously introduced, have been doing some research behind this procedure in treatment for osteoarthritis. In our patient population, we saw that at the 1 month mark after their procedure, 100% of these patients had a significant decrease in what we call the WOMAC score and a 95% decrease in their VAS score. These questionnaires are important in the orthopedic literature to help stratify patients and see how their pain is, their activities of daily living, their overall function, and their mobility. So all these questionnaires were given both before and after this procedure. And at the 1 month mark, there was a significant decrease in both their pain, their increased range of motion and function. And at the 6 month mark, this still persisted and had significant decrease in that pain and improved function. Majority of these patients were able to decrease their NSAID use at that 6 month mark after their procedure as well, which is great based on some of the talks that we had earlier about these medications not necessarily being benign. We performed another study as well, so some more research that helps us support this procedure, where we did a randomized control trial for patients that were either separated to receive this procedure, the GAE procedure, or not. And in 100% of patients, they reported improvement in their pain with the procedure. The patients that did not receive the procedure were then allowed to get the procedure, and they also reported improvement. And again, we're noticing some of these questionnaires like the WOMAC and VAS scores, which are pretty standard within the research guidelines for orthopedic surgery. Now, we're not the only ones performing research for these types of procedures. So some of our colleagues at UCLA were able to replicate some of our studies and find the same thing, a significant reduction in pain and improvement in their overall function as well. We've also been able to take a look at our procedure, the GAE procedure, and compare it to some of the other procedures like hyaluronic acid and steroid injections, some of the radiofrequency ablation procedures as well. And you really have overall pretty similar patterns of improvement there. The GAE procedure was really able to get a nice statistically significant amount of pain reduction. Less so sometimes with steroid injections or the hyaluronic injections as well, and even so much with the radiofrequency ablations. But it was a pretty tight and consistent amount of consistent pain relief associated with the genicular artery embolization procedure. All right, so who is a candidate for this therapy? So for the genicular artery embolization procedure, we typically like to see any patient that's having pain, but a lot of the patients that we'll see referred by their orthopedic surgeon or their primary care physician are patients that have tried physical therapy and the physical therapy hasn't worked. The exercises are hard. It's hard to have weight bearing on that knee as well. And a lot of times insurance companies want you to try physical therapy as well. So standard of care usually dictates to try that. If that's not working, then we can escalate your therapy. Other therapies that you've tried that have not worked. So going back to some of those steroid injections, those hyaluronic acid injections, or nerve ablation therapies that have not worked. If you have physical pain, so if you're able to push on your knee joint and that causes some pain, that's a good sign that you're going to receive benefit from this procedure. What we call palpable pain, or pain where when I push on your knee and it kind of reproduces the area of pain that you're having, is a good sign, because that means you're going to respond well to the therapy. If you have imaging that shows synovitis, whether that's an MRI, an ultrasound, or even sometimes x-rays, we can pick up on this as well, you'd be a good candidate. Now, there is a small population within the knee arthritis kind of world of what we call a hemarthrosis patient. These are patients that have such bad arthritis that their knee starts to swell up with water and that needs to be drained out. Sometimes that water inside that joint space can be bloody because of all these blood vessels that we talked, these abnormal blood vessels that have developed that are kind of leaking a little bit of blood into that joint space. So these patients respond very well to this therapy. And then patients that have more mild to moderate arthritis within the knee joint are really good candidates. The more severe or bone on bone that arthritis is, the therapy does still work, but might not work for quite as long as some of these mild to moderate patients that we see. And we can kind of take a look at that based on x-rays or other imaging that you have available. In terms of a workup or what happens before we jump all the way to a procedure, a lot of the times this is already performed by either your primary care physician when you bring up your knee pain to them, or your orthopedic surgeon if you've been referred to them. Here at Loudon Medical Group, the Orthopedic Group, the orthopedic surgeons here are very good at doing a diagnostic workup to make sure that we're checking all the boxes, making sure we're not missing anything, and working with you to make sure that we provide the appropriate therapy for you. A lot of the times this will include some sort of imaging like we discussed, whether that's an MRI, x-rays, or ultrasound. That can give us clues as to where exactly this problem is, if there's anything else that needs to be addressed with surgery or not. Some routine labs can be helpful. Within the last year are fine as well, just your standard labs, making sure that all your blood counts are appropriate, no issues with any bleeding risks or anything like that. It's always nice to do a physical examination as well. So on the day of my procedures, I always take a look and work with my patients, really feel exactly where they're feeling the most pain. And that can aid me in terms of the procedure as well as to where to target. And we'll talk about that during some slides I have coming up. And like I briefly mentioned, an orthopedic surgery evaluation is always helpful to go over what treatment options are available, what your best route might be. And, you know, doctors, the Loudon Medical Group, orthopedic surgeons do a great job of really providing some tailored care and going through different treatment options that are best work for you. Here's a little schematic or diagram of what to kind of expect or what happens. In this example here, we are entering the blood vessels at the top of the leg or the groin area. Majority of the time for our patients that we're working with nowadays, we actually enter the blood vessels at the level of the foot or the ankle. It's a little bit of a more comfortable procedure for patients, less recovery time as well. But again, this is all tailored from patient to patient, and we can certainly talk about that during consultations as well. But for this video diagram here, it's a little video that goes over what exactly we do. So under imaging guidance, we're able to enter a blood vessel, whether that be at the level of the ankle or here at the top of the leg. And under live x-ray guidance, we're able to navigate into the blood vessels that supply the knee joint. Here, for example, we perform an angiogram of the blood vessels of the knee. And then under live x-ray, we're able to subselect some of these arteries that are inflamed or are abnormally increased. What we do then is deliver medications or particles to reduce the amount of blood flow while keeping the main artery nice and open and healthy. Once we're all done, we remove the wires and catheters that we use, and we either hold some pressure or use a small little stitch to close up the artery. The entire procedure takes about 45 minutes to an hour. So what do I see on my x-ray machine? So the images on the right-hand side are what we call angiographic images. The black are the blood vessels that we see. We use contrast dye under x-ray, which helps to light up some of the blood vessels for us. On the left-hand side, we have a number of blood vessels that are highlighted here. What's important really is that there's a number of blood vessels. There's about 6 of them total. And during this procedure, we interrogate all of them to take a look and see if there's abnormal increased blood flow. Now, we may not treat every single one of them because everyone's bodies are different. Their degree of arthritis is different. Their pain is different. We'll still take a look at all these blood vessels, but based on the findings and participating with you sometimes in the middle of the procedure can be helpful in terms of treating. All of our procedures, for the most part, are performed with what we call moderate sedation or twilight sedation. So when you come into our office for the day of the procedure, we'll start by placing an IV to provide sedation. We don't use an anesthesiologist or a breathing tube, but just enough sedation to keep you nice and comfortable. Some people are sleeping throughout the procedure, but some people are still awake and comfortable. My goal is to keep you comfortable throughout the procedure, not necessarily to knock you out completely. One of the reasons for that is if a blood vessel, for example, doesn't have a huge amount of blood flow, but still looks a little abnormal, then I'll work with you a little bit. You might feel a little warm inside the knee, and that can kind of correspond to sometimes of where you're experiencing pain. And if you're awake a little bit, we can have a little conversation in the middle of the procedure to see if the area that I'm targeting on the X-ray corresponds to the area of pain that you normally experience. And if you say yes, then I proceed forward and I treat that blood vessel as well. So it can be helpful to have you participate in your care as well. Here, for example, we're able to catheterize what we call the descending genicular artery. This artery is really important as it supplies some of the inside or medial aspect of the knee joint and kind of that the kneecap as well. So arthritis related to that area gets addressed really well by this blood vessel. Here it's just highlighted over here in terms of what blood vessel I'm looking at, where the catheter was placed, and where the material that we use to block off the blood vessels goes. So I'm going to go through a few different ones here. It might be a little much in terms of here, but what I'm really looking at in this image here on the screen right is a subselective catheterization of one of the arteries. What my eyes go to on the screen is this abnormal, cloudy, fluffy material here. So what I'm trying to point out right here on the screen, this abnormal amount of fluffy gray, that's not normal here. Normally, I shouldn't be able to see this much amount of gray here. What this gray is, because we're using contrast, these are blood vessels. These are small, very, very small, barely perceptible to the eye blood vessels that have developed as a result of the arthritis. And this is the target of what we want to do. This is our normal, healthy artery that we're all born with, but over time with arthritis, it starts to form these abnormal small blood vessels, these small, small, small ones that have developed. And that's what we're trying to reduce based on this procedure. Here's another example of a particular artery that we're able to subselect and catheterize. And this one shows a nice example of the synovium. So here under X-ray, you can see the bones itself of the knee joint. And this abnormal blood flow here, or this abnormal gray, is that lining that we talked about. Notice how it's kind of further away from the bone. That's because it's thickened and has that abnormal increased blood flow. Another example here, this one's a little bit lower on the knee joint that can kind of affect that inside portion of the knee that we target as well. So a lot of these just looks like a lot of black lines on the X-ray screen, but to a trained interventional radiologist, these pop out right away and I know exactly where I need to go to help treat you. Another example here, this one's towards the outside of the knee, below that kneecap area that can provide some pain in that area that we'll treat pretty frequently as well. And then another example here towards the outside of the knee. So about 6 arteries in total that we do interrogate. Again, we don't necessarily treat all of these. It really depends on the result of the angiogram, where your pain is, where a lot of the arthritis is present throughout the knee. And that helps us treat some of these blood vessels. Now, what does it look like? What are you talking about when you're blocking off a blood flow? That sounds a little scary in terms of cutting off blood supply. The concept of embolization, which is a medical term where we reduce or stop blood flow within a blood vessel, has different meanings. Here, for the GAE procedure, we're not trying to shut down a blood vessel in entirety. I don't want to do that. You do need some healthy blood flow towards your knee joint to keep it healthy. What I'm really trying to do is take it from an abnormal high down to a normal level. What that looks like for me on X-ray, on screen image left here, we're seeing some of that cloudy, fluffy gray here. Those are those abnormal blood vessels that we talked about. Once we give our medications or treatment, then that reduces down. So see on the screen right, these are images after we've done an embolization procedure. And I don't see that cloudy, fluffy material anymore. That's what I'm looking for. But these nice arteries are still open. They're still healthy. They're still supplying blood flow towards the bone, for example, towards your skin, towards your muscles. Those arteries are not impacted by this procedure. So I always like to kind of bring this back to patients. This is an example of a patient that we worked with. This was a 57-year-old gentleman who had a partial right knee pain, not right knee replacement because of pain. About 10 months prior to when we saw him, he was having persistent pain all throughout the knee. And he'd also, in the post-operative period or after surgery, had developed some of that water building up in that knee joint, what we call effusions, and had to have a needle placed into the joint space and kind of emptied out. So his pain was mostly on the top of his knee, and that's where he was tender as well on physical examination. So these were some of the images that we were able to take for this patient. So on the image on the left, this is our initial angiogram. This is where we're able to use a catheter and inject contrast dye into the arteries that supply the leg and take a look at some of the blood vessels. On the middle hand image, we selected one of the arteries that bring blood supply towards that top of the knee joint area where this patient had palpable or focal pain. And what we see is this abnormal amount of blood flow. All this dark gray is abnormal. That's way too much blood flow coming to that area, which leads to more nerve fibers growing there and causing a pain signal. After treatment, this is what this looks like here. So after we delivered or embolized some of the embolic agent, this is what the blood vessels look like now. So that abnormal fluffy gray is gone. The main blood vessel still remains open and it's healthy and it's giving the adequate blood supply and nutrition to that knee joint without being too much. And this is what the other artery looked like on the opposite side. So again, on the screen left is this really dark grayish material all throughout this side of the bone and the knee joint here. After treatment, that's what this artery is trying to show. The artery is still open, it's healthy, it's sending these healthy branches out towards the skin, the muscle, but the abnormal amount of blood flow towards that synovium or the lining of the joint space has been treated. This patient did very well. They were discharged home the same day from their procedure. We do provide both an antibiotic after this procedure to prevent infections, as well as a short course of a nonsteroidal inflammatory agent for a few days as well. The reason behind this is that you may experience a little bit of stiffness or soreness for 1 to 2 days immediately following this procedure. It does get better with time though. Sometimes you can develop a little bit of a lace-like skin redness or rash, similar to what this patient has right over here overlying the knee joint. That's normal and to be expected. It does go away with time though. We evaluate our patients at the 1 month mark to see how they're doing. This patient did very well. He reported his improvement already at the 2-week mark, was no longer having to get his knee joint drained and was able to get some nice results. So overall, this isn't an immediate flip of the switch procedure. It does take a little bit of time for these procedures to take into effect. Pain improvement, most of that occurs in the first 2 to 4 weeks. We do follow up with our patients at the 1 month mark to see how they're doing. Sometimes it can take up to 3 months to get the full benefits of this procedure. From that amount of time, our patient population and experiences showed us that about 2 years is the amount of time of pain relief you can expect after having this procedure. One of the benefits of this procedure is that it can be repeated as well. So I do have a patient population that I work with where they've had a procedure once before. They had really good results with it. They're either not a good surgical candidate because of their medical problems. For example, they can't undergo general anesthesia. Physical therapy after a knee replacement can be pretty intense and they're not able to participate with that. Or they're just not interested in having a knee replacement. And for them, having this procedure to give them a couple of years of pain relief is enough for them, where they don't mind coming in for an hour procedure to give them a couple of years and see me every so often. So that was my little presentation that I had about genicular artery embolization. I'm certainly going to open it up to you guys for any questions that you may have as well. But if you're interested in learning more about some of the procedures that we have available, whether it's the GAE procedure, other joints that we treat, such as the shoulder or the hip, or just want to learn more about some of what we do, feel free to give us a call at our number here or our email address that we have as well. If you do want to scan the QR code, that'll give you some more information about our facility as well and how to get in contact with us to set up a consultation. And again, all this information will be recorded and sent out to you. So if you signed up through your email address, one of our administrators, Marco, will be sending the video link probably by tomorrow as well. So I'm going to just take a look and see if we've got any questions from the audience here. So two questions were, does insurance cover this or does Medicare cover this? Medicare will certainly cover this. Majority of private insurance companies are also willing to cover this procedure as well. It's certainly getting a bit more popularity with private insurance companies as well, but Medicare certainly covers this. One of the benefits of working with our company is that we have a dedicated team that works with your insurance company. So after you and I are done having our initial consultation, I submit all of the notes, the imaging, everything from your family doctor, your orthopedic surgeon, as well as myself over to your insurance company and get what's called a pre-authorization. So we'll submit everything that we're looking to do ahead of time. That way, if there are any issues, any denials, our team will be aware and there's no surprise bills on your end. If there are any denials, my team will even work with you for that. So sometimes I can get on the phone with one of your insurance providers and have what we call a peer-to-peer conversation. I just did this for one of my patients yesterday, kind of explain the situation of what's going on, what we're looking to do, and I was able to get that overturned for her. So we're here to work on your side. The insurance companies can certainly sometimes give us a little bit of some issues, but we've been working really well with them, and they've been seeing a lot of the research we've been doing too. And when the evidence is right in front of them, they can't really deny some of the numbers. So yes, to answer that question, yes, insurance will likely cover this. The second question was, what if you've already had a full knee replacement? I'm about 2 years out from surgery coming this August, and I still have knee pain. Yes, we can still do this even if you have a knee replacement. So the example that I showed, a patient had a partial knee replacement, but we've done this procedure on patients that have a full knee replacement. I've done this procedure on patients that have had a revision knee replacement where they have even more metal. So I've got all the tools and tricks that I need in my operating room to provide this procedure for you. It does work very well for patients that have a knee replacement as well, just from all the inflammation from the surgery, some of the scar tissue that forms. You are still a good candidate to have that done. Let's see. So next question that we have here is, if PRP has been done already, is this procedure still appropriate? That's a great question. PRP is a great therapy for knee pain as well, and as well as some of the other injections that we have available. But yeah, if you've had a PRP injection, a steroid injection, or a hyaluronic acid injection, you're still a candidate for this procedure. The PRP won't interfere with anything that we do for this procedure. And likewise, if this procedure won't get in the way of a surgeon doing anything else either. So by doing this procedure, you're not jailed out from having a knee replacement in the future, having a nerve ablation or an arthroscopic surgery, anything like that. And then another question was, is this part of the group with Ramon Candile's group? Yes, we work with Dr. Candile. We work with him, his partners, which include Dr. Akhtar, Dr. Kavanaugh, and Dr. Gavin, as well as their PAs and NPs. So yep, we're all part of that same group. So some of the other questions that we will have on occasion is, the overall things to expect from a day-to-day basis. On average, you're usually with us for about 3 to 4 hours out of your day. Like I said, though, the procedure time itself is about 45 minutes to an hour. You arrive ahead of time. That way we can work on your IV. We start some sedation process as well ahead of time to keep you nice and comfortable. And then we do our own imaging while you're here. And basically, I like to take a look at the blood vessels that you have present, take a look at the joint as well, see if there's any fluid building up in that joint space, and then have a conversation with you about where your pain is, kind of mark off exactly where it is and work with you to help tailor your treatment towards where your pain is. From that standpoint, we would bring you back to our procedure area. We clean off your skin with an antiseptic solution. And the first thing that we do is provide some local numbing medication. That's similar to before you get a filling at the dentist's office where you feel like a sharp bee sting or a pinch and burn for about 10 to 20 seconds. And then that starts to go away and your skin's numb. Then under imaging guidance, we're able to insert a small wire and catheter, which is about the size of a hollow piece of spaghetti, into your artery, whether that's at the level of the ankle or at the top of the leg. And under imaging guidance, insert that catheter and navigate towards that knee joint, and then do the procedure like we kind of talked about in that video and some of those still images that I showed earlier. From that standpoint, once we're all done, we remove all the wires and catheters and hold some pressure at the puncture site, or use a closure device, which is like a suture-mediated device to close up that artery and keep you in the recovery process for about either an hour or 2 hours, depending on the artery that we went into, making sure the sedation's wearing off, you're feeling okay, providing you with some snacks since you're probably on an empty stomach from the sedation. Then you do go home that day. So we, expect you to go home that day, walk out of there. We don't routinely recommend braces or using crutches unless that helps you with your pain. Again, everyone's degree of knee pain and a degree of arthritis is a little different. So that's always going to differ from person to person. If you're undergoing physical therapy or in working with a physical therapist for your knee, we'd like to just recommend holding off for about 2 weeks just to let some of that inflammation and stiffness wear off before you go back towards it. The main limitation after this procedure is just no heavy lifting, anything greater than 10 pounds for about 5 days after this procedure. But it's pretty well tolerated. Most patients are either asleep throughout the procedure from the sedation or nice and sedated and comfortable throughout it. All right, one of these questions is, I have 2 meniscus tears from a ski accident in 2019, and I've never really done anything, and my knees are constantly in pain. Will this help? It certainly can. So a meniscal tear can definitely cause a lot of inflammation and swelling within that knee joint. It can cause some swelling to local structures or other structures within your knee joint. So that means tendons, the other capsule around that knee. So you'd certainly be a good candidate to have this done. Again, everyone's medical decisions are kind of on a case-by-case basis. So this is certainly something that I would discuss with you during a consultation to see if you'd be a good candidate or not. The next question is, do you need to have it done again and again as you age? So on average, this can last you about 2 years. It can be repeated though, to give you some more relief. So if it's working for you the first time, again, 90% of patients are reporting improvement in both their pain and improvement in their symptoms. So for the vast majority of patients, they do report some sort of pain relief and improvement in their symptoms. So it certainly can be done again if you need to. Not everyone does want to do that. Sometimes they want to try something else out, whether that's an injection or if they want to proceed with a knee replacement, they can certainly do that as well. But yes, it can be done again and again. I've done this up to 3 to 4 times in a patient before over the span of a number of years. Is this more effective than gel shots or gel injections? It can certainly be helpful for that. It's a different concept of what we're trying to address, though. The gel shots certainly try to fill up and kind of give some sort of a filler in between those 2 bones that we have in that knee joint space. A lot of gravity being put on there. So as that cartilage starts to wear down, the gel shots try to fill that space up a little bit and take some of the pain off from that bone on bone. This procedure doesn't really help to fill in that space, but certainly can work with gel injections as well and helps to reduce the overall inflammation and pain associated with that. And I think we definitely need some more research that kind of compares some of these different treatment options available to see kind of what's really out there, what's the standard of care, and is this better than that? And then in terms of risks, great question. So the main risk that we'll see for this procedure, because we're working with blood vessels, is bleeding. And what I mean by bleeding is what we call a hematoma, or a collection of blood at the puncture site. Happens in about 5% of patients, more common in those that are on long-term blood thinners. For example, patients that take medications such as Eliquis, Coumadin, Plavix, or aspirin, and can't come off of those medications. It can certainly cause a little bit of bruising or a bump that tends to go away. We haven't had any problems with patients developing blood clots or excessive bleeding to the point where they need to be transferred to a hospital or anything like that. Then the other ones that we kind of briefly mentioned, a little dull achiness into that knee joint for about 2 to 3 days after this procedure. You might feel a little bit of itchiness on the skin overlaying the knee, or a little bit of that rash that I showed before. Is GAE as successful for shoulder pain and frozen shoulder? This unfortunate person has one of each. So yeah, we do have research that shows that this procedure that we perform for the shoulder as well, we've had webinars in the past for that as well. It really helps well for patients that have what we call adhesive capsulitis, where that thickening of that shoulder joint is causing that restricted motion for frozen shoulder. It works a little less for patients that really have bad arthritis in that shoulder joint. It still works, but just not as well. Where is this procedure performed? So our office is in Lansdowne, off Sandridge Way. It's in an office-based lab, so it's not associated with the hospital, but we perform this all in our office. We have all the equipment and staff that we need to perform there. If you have multiple joints that are problematic, can this be done for all of them at the same time? I wish. That's a great question. So I try to just focus on one joint at a time, just because there are so many blood vessels involved, and just the way of the logistics of going from our puncture site, whatever blood vessel we're working on, to address them. So I try to do one joint at a time. If, for example, if both of your knees are painful and you want to start on one side, well, it can, maybe start on the left knee, treat that, bring you back in 2 weeks, treat the other one, and kind of go from there. But I like to try to space them apart. Number one, like we said, a little bit of that downtime in terms of having a little bit of stiffness or soreness for 2 to 3 days after. Definitely want to just treat one joint at a time to make sure that you're doing okay and your overall mobility isn't being affected. Is this procedure done for hip pain too? Yes. Yep. We did a webinar a couple months ago to go over the same concept behind this procedure for patients that have hip pain, whether that be for arthritis or what we call bursitis of that hip, and it works very well for those patients as well. Does this cause blood clots? That's a really good question. So we haven't had any issues with patients developing blood clots after this procedure. What we do is actually use a medication. It's actually an antibiotic that we use to help block these blood vessels. So normally a lot of these patients that have infections in the hospital, for example, receive medications like the ones that we use for infection. We're using it for a different purpose. We actually change the chemical properties of this antibiotic when we mix it with some contrast dye. Normally it's like a colorless water type of a medication. And when we mix it with contrast dye, it forms salt crystals. And these salt crystals then act to block off these blood vessels. So we administer these salt crystals into these abnormal blood vessels that you saw before. And this blocks off the abnormal blood vessels, but keeps the main arteries nice and healthy. What's nice about these agents is that they're what we call resorbative. So they're not permanent. They go into the blood vessels and block them down for a number of days and then slowly open back up. The amount of time where those blood vessels were shut down is sufficient to decrease the overall amount of blood flow and to starve nutrition from some of those nerve fibers that have developed into that knee joint. So nerves, just like any other cell in your body, needs an adequate blood supply in order to maintain its normal, healthy state. And if we're able to decrease the amount of blood flow for a period of time, that helps to restrict blood flow from those nerves and they start to die off, and then that pain signal starts to go away. All right, and then I believe this one's the last question that we have for now. Since this is a relatively new procedure, are there any long-term issues that could be created? Not that we've noticed any so far. So in terms of our cohort of patients that we've been following for a number of years, we haven't had any long-term adverse side effects that we've seen. And again, like we mentioned before, because we're using an agent that's not a permanent agent where we're completely shutting down the blood flow, there's nothing that's implanted into your body that's going to be there long-term. All right, just want to make sure we've answered everyone's questions there. And certainly, if there's more questions, feel free to reach out. We can certainly set up a consultation as well, where we're able to have a little bit more of a tailored conversation regarding your health and your particular needs as well. But I'm certainly happy. If there are any other questions, I can certainly take them. But otherwise, this webinar will be recorded and sent out to you all as well, so you'll have something to reference. But otherwise, we're certainly looking forward to working with you all. And feel free to reach out via either phone call or email or scan the QR code, and we'll get you set up for a consultation. And hopefully, we can help you with some of the pain that you all have been having. But appreciate everyone taking the time out of their busy weeknights and having some time to speak and learn some more information about some of these newer procedures that we have available. A lot of the times patients, when I'm talking to them, have no idea this even exists. And that's because a lot of the times their referring physicians don't know that it exists either. So it's helpful to have these types of forums where we're able to go over some of the data behind why we're doing a procedure, how it works, and how it impacts you as a patient. So thanks for joining me tonight. It's been a pleasure going over some of this information and looking forward to meeting some of you guys soon. All right, have a good one. Bye-bye.